folks in the back of the room, if y'all want to move up and sit behind the legislators, that's fine. You don't have to stand up.
Get on the back.
Come on. Just take up the back few rows.
Yeah, we don't fill up.
Maybe, Demetrius, why don't you move up a little bit? There's some Democrats up here you may like.
Or not.
I know not Billy Mitchell, but the other two up there you may like.
Devin.
See Greg Conley.
You may not be Devin. Oh, he's not.
Committee members, if you would move up to the first two rows, and I'll tell you, Chiefs, if y'all don't mind moving back, yeah, one, because we're going to have some more committee members come, and I apologize. I have purposely set this up today to hear from the DOI and Mr. Elliott before we hear the bills, because we have members coming in late. We had a number of things going on today. So this is sort of backwards. Also, from now on, we'll be in 403 for committee members. Much better room for us. We can see y'all around the table and be able to recognize you for questions. But today, we're doing it this way and it's going to work. I'd like to thank everyone for showing up today and committee and the folks that are here to speak to the bills. I'd like to go ahead and start off with Greg Conley. I think, is he here? Yeah, Greg. Greg is from the Department of Insurance. If you'll come up and speak to us. Let's see. Try that.
How about now? Hey, there we go. Thank you, Mr. Chairman, committee members, guests. I'm here to present to you sort of some initial findings from a market scan that we did. Commissioner King has made it sort of one of his priorities to sort of really take a look at health data in the state. And so we received a grant from the federal government for states that had enacted 1332 waivers to do a health scan on both the network adequacy in the state of Georgia and the uninsured population in the state of Georgia. So these slides are going to kind of take you through kind of what we did. So I'm going to start off with the network adequacy data. And what you can see here is a map of the state of Georgia that kind of gives you an idea of where we lack network adequacy. And I want to kind of take you through what each one of these kind of criteria states. So where you see it says the summaries, what we have here is 644,000 total consumers covered by this study. These are consumers who are eligible for ACA plans. That means individuals who earn between 100% and 400% of the federal poverty level. Federal poverty level at 100% is approximately $13,000 for an individual, and I think approximately $27,000 for a family of four. So it's someone earning $13,000 a year as an individual up to approximately $52,000 a year. That's kind of the population we're looking at. So what you see here, when you see uncovered Uncovered does not mean that they have no coverage. Uncovered means that CMS defines 27 key specialties, medical specialties that everyone is supposed to have access to. Uncovered means they don't have access to at least one of them. So it doesn't mean they have access to no doctors, but it means they lack access to certain doctors, and we'll kind of dig into that a little bit here in a moment. The uncovered by carrier, what that tells you is what percentage of their plan members in the state are uncovered by a certain specialty. So for instance, carrier number 6, 33% of its members in the state are uncovered by some type of critical specialty. And then finally, uncovered by plan level, what that tells us is in ACA plans, you buy a gold, a silver, or a bronze type of plan. This tells us what percentage of those individuals purchasing those plans are uncovered by one of these criteria. And so you can see the real trend in the state of Georgia is when you move out from Metro Atlanta, you start to see a lack of network adequacy. And I'm going to give you some specific county data to kind of illustrate some of the things that we're seeing. I would say one of the large trends before I get to county data is you'll notice that 12.7% of the individuals in the state eligible for ACA plans do not have coverage from an allergist or an immunologist. And what that means is CMS defines access as certain drive time limitations based on the county you live in. So if you live in a large metro county, for instance, a primary care specialist, you're supposed to be able to drive to them in 10 minutes. If you live in a rural county, you're supposed to be able to drive to them in 25 minutes. And so that's when we're defining not covered, we're talking about distance to care. And you can see some of the worrying criteria are cardiothoracic surgeons, vascular surgeons, ophthalmologists, and neurosurgeons. There's a significant number of Georgians who are not close enough to doctors who have these specialties, and this does not include the amount of time it takes to get an appointment. So we're just saying how far are you from them. We're not saying you can readily get an appointment. So that's kind of the statewide picture. But what I really want to do is I want to dive into individual counties to kind of show you some trends, and we can do this for any county in the state. We kind of pulled some different ones from around the state, but if you want to know what's going on in your county, we can actually show you. So the first county we pulled was actually Hall County for Chairman Hawkins. And what you can see in Hall County is that based on the ACA population there's a very, very small number of uncovered people in terms of drive time. We have 9 consumers who are not within drive time limitations of an OBGYN, and 6 who are not within drive time limitations of an orthopedic surgeon. And that essentially means that their drive is a little bit too long. Now, once again, this is a Metro Atlanta county, and that doesn't seem very worrying. And you'd expect that with Gainesville. There's sort of a large town that can provide medical services. But as we kind of get farther and farther away from Atlanta, you're going to start to see sort of things change. So the next county we did was, and I want to kind of take you on a trip here up 515. So Pickens County, if 575 finishes off, you run into 515. Pickens County borders Cherokee County, pretty close to Metro Atlanta. We see no one uncovered. If we continue north to Gilmer County, we see, once again, single-digit individuals who have trouble reaching care. If we go to the next most northern county, though, Fannin County, what you see in Fannin County is you see a significant number of uninsured. So you have 45% of individuals in Fannin County who are eligible for an ACA plan are not within drive time distance of an OBGYN, which is troubling, very troubling. Urologists, ophthalmologists, neurologists. This is a troubling statistic, but what you can see is neighboring county, Gilmer County, you don't see the same drive time issues because of Gilmer County is just that much closer to Metro Atlanta. And part of what this illustrates is to address network adequacy in the state of Georgia, there isn't going to be a one-size-fits-all sort of ruling we're going to be able to make. Different communities are going to take sort of a different approach. So moving on to...
Excuse me.
Oh, yes, go ahead.
Do you mind leaving Fannin County up there just a second if you can?
If I can go.
Just
Yeah.
understand, other than uncovered by carrier,
Yeah.
you've got carrier 1. It looks like, are there 5 carriers that cover that county, 2 of which have significant
Correct.
groups of uncovered? So those other 3 are available.
Yeah.
Do people know that before they pick their ACA plan or renew their ACA plan? Do they know, they see that there's 5 names there? Is there any disclosure of the fact that 3 of them look like they have pretty good coverage, if I'm
Yeah.
reading this right.
So when you compare plans when you're signing up for an ACA plan, that's the correct way to read this. Yeah, you can see the size of the network. You can see the doctors that are network in your county if you want to. So you do, I would say, theoretically have access to that. How well the average consumer is able to understand what this means is a different question. And so I think there is a significant gap between when consumers sign up for insurance believing they have access to a physician as opposed to whether they actually do. And I think one of the things we're starting to question is, why do certain insurers have lack of access while others insurers do? What that tells us is there's not a lack of doctors, right? If you have 3 carriers that you can get access to a doctor, that means there's doctors in the community. It means that they're not in network with certain carriers. And so the next set of questions we'll be going through with this data set will be why those characters, or why those carriers, why those communities. But yeah, that's exactly right. Yeah.
Thank you.
So moving around the state a little bit, Glynn County was also an outlier. You can see in Glynn County, you have incredibly high levels of lack of access to care in very, very important specialties. So 91% of the people in Glynn County who are eligible for an ACA plan are not within proper drive time distance of a cardiothoracic surgeon. Over 50% for dermatologists, neurosurgeons, cardiologists, general surgeons. And, I think for a lot of us, when we think of Glynn County, I think of going down to the coast, and you think of it being like relatively, at least if you're out near the water, relatively built up. But what it tells us is the infrastructure, the way that the carriers have structured their plans in Glynn County shows some very, very serious gaps. And you can see there's only 2 carriers in Glynn County, and both of them lack significant coverage for their members. And once again, as we try to regulate something like this, we're trying to regulate a market that includes Hall County, which has very low numbers of uncovered, and Glynn County, which has very high levels of uncovered, which could be attributed to several things. One, Glynn County is relatively close to Jacksonville, and a lot of the carriers might be assuming people will find care in Jacksonville. You also have a lot of seasonal residents, so you have a lot of people who are not going to live in Glynn County full time, so they're not expecting to get their care in Glynn County. But once again, right now, we're just getting a picture of what the market looks like. And as we dig into this data a little bit more, we'll start to answer some of these questions of why these dynamics exist. Moving to the middle of the state, if we look at Emmanuel County, you can see there's the high levels of lack of coverage deal with really allergy and immunology, which is sort of a statewide issue. Once again, you have one particular carrier that's lacking in coverage, 3 carriers which seem to have coverage. If we move to Johnson County, same thing, allergy, immunology, dermatology, ophthalmology. Once again, one specific carrier. If we move to Lawrence County, and you're starting to see we're moving into the dark blue part of that map, and you'll notice if you've looked at any of our reinsurance numbers, that dark blue area of the map is not only an issue with respect to network adequacy, it's an issue with respect to the number of carriers, it's an issue with the number of hospitals. It's sort of in terms of health outcomes, it's a hard part of the state. You can see in Lawrence County, 96% of people eligible for ACA plans do not have appropriate access to a cardiologist, which is incredibly concerning. Once again, OBGYN, 85% of the individuals who live in that county who should have an ACA plan are not within proper driving distance of an OBGYN. Something which I think you would consider just basic healthcare, right? So very, very troubling statistics depending on where you look in the state. If we stay in the same area, Treutlen County, we have one carrier, and 100% of its members do not have access to one of the defined specialties by CMS, which is very, very troubling. If we move just a little bit farther in the state, if I go to Lamar County, you'll see everyone has the proper drive time distance. It's very similar in Spalding County, almost no difference. And we have a small number of people in Monroe County who do not have access. And so what you see is, you can see that Monroe County is just a little bit more blue than either of the other 2 counties that I previously mentioned, and it's because just being a little bit farther from Metro Atlanta it makes a massive difference between what type of access you have to doctors and what type you don't. And so as we try to solve the network adequacy question, it's going to have to be like we're going to have to sort of carve at the joint a little bit. We're going to have to get a little more technical with how we define access to care. But that's sort of what we're seeing around the state with respect to network adequacy. Before I move on to the uninsured population, are there any questions about this presentation in particular? Nothing? Okay. This is a health market scan. This is the uninsured analysis. Now, both of these presentations can be as granular as you want them to be. I'm giving you really high-level stuff here. But just a note, I can give you the county data for the chart I just showed you. If you want to know what's going on in the counties in your district, I can show you. This is a study of the uninsured population of Georgia. So these are individuals eligible for ACA plans. That means between 100 and 400% of the federal poverty level who do not have insurance. And so what we did is we compared census data, compared with who we know is eligible for plans, and we're able to get a pretty good picture of who in the state does not have insurance, who we would hope have insurance. So I'm going to give you some high-level lessons we learned. Some of them are probably not going to surprise you, and then I can give you some more specific stuff. But there are really eight takeaways. One is that changes in premiums, net premiums. So for ACA plans, you're not paying the entire cost of your health care. The federal government is subsidizing it, yes? So changes in net premiums, that means the subsidized thing you pay, not the full cost, have pretty significant outcomes for people, especially between 1% and 200% of the federal poverty level. Unmarried, childless people enroll far less frequently than others, which was not a huge surprise, but marriage and children definitely make you enroll healthcare at a higher rate. African American and Caucasian Georgians are unenrolled and uninsured at almost exactly the same levels. Different parts of the state, but at almost exactly the same level. Housing status makes a difference in enrollment, specifically renting versus owning. We see a significant difference between individuals who rent and own and who signs up for insurance. Access to a physician. So particularly in and around Atlanta, perceived access to a physician can make a big difference in enrollment numbers. And what that means is, if you live in Metro Atlanta, you're probably not that far from a doctor in terms of how the crow flies, but how far are you from that doctor in terms of travel time? So for instance, if you have to take public transportation, is it a 5-mile journey, but a, hour-long trip on MARTA? Higher education suggests an impact on enrollment, but not that much. There's not huge differences. And then neighborhood clusters, and we mean census tracts around Greater Atlanta, especially in Gwinnett County, which Gwinnett County is a serious outlier, shows some significant differences. And finally, that polymorbidity is associated with higher enrollment for people as they get older. And so those are kind of like high level takeaways, but I have some more. I can get a little more granular for you. So you can see here what this is individuals at federal poverty level between 100 and 149% and 150 and 199%. If premiums change by $50, we see a drop in enrollment at 6% for people at the 1 to 149 and 14% for 150 to 199, which means those populations are particularly sensitive to small moves in net premiums. So any changes we make in the market that will even slightly increase premiums can have drastic results for individuals who are not insured. And the uninsured population is large. We estimate about 1.5 million Georgians. So that's a very large move. So when we say 10%, we're not talking small numbers. We're talking maybe 100,000 people for a $50 change. So when we talk about the reinsurance program and we talk about the savings that it gives, they may seem modest, but those modest changes make big differences to a lot of people in Georgia. What you can see here is the numbers for unmarried and childless people. You can see that the unmarried and childless population of Georgia enrolls at about 25%, whereas people who are married with children or married with no children enroll at about a 47%. And what this really tells us is, as we start moving into trying to get more Georgians health insurance, these kind of data points tell us who are we trying to reach and what, tells us a little bit maybe why they're not getting insurance. So if you know that a large part of the population are single, they don't have children, are not signing up for insurance, you can sort of start targeting your advertising towards those individuals. So you might think like, yeah, young single people don't want to sign up for insurance, but how do you actually reach out to them? On our next chart, you can see marketplace enrollment by racial groups, and you can see that Asian Georgians enroll at a much higher rate, almost twice as at the rate of any other racial group. You can also see that African American and Caucasian Georgians enroll at almost the exact same rate. And then there's a slight rise for Hispanic Georgians, and then everyone else once again kind of tracks the same. Which is an interesting statistic. What's troubling about it is how low the enrollment numbers are. And so what we're seeing is a move to get all Georgians insured involves reaching out to essentially every group there is. It can't be like we're just targeting one population, we have to hit everybody. What we can see here is these are clusters of uninsured around Greater Atlanta. And you can see that the actual city of Atlanta and that sort of central part of Fulton County doesn't have a giant cluster of uninsured. Where you see the clusters of uninsured is especially in Gwinnett County, up into Forsyth County. That's where you start to see large clusters of uninsured. And so you can see in the on the right, sort of our interpretive portion of this, that these clusters exhibit higher unemployment and lower incomes than other parts of the state. There are more African American residents and fewer Asian residents. They're more living without credit or debt, and higher rates of substance abuse and asthma. And these are just sort of census facts that we're sort of seeing in these populations. And so that kind of makes us want to dig into Gwinnett County a little bit. So Gwinnett County is an outlier in the whole state. It's completely different in terms of the uninsured population than we're seeing in any other part of Georgia, which makes us want to dig into it a little bit. So one of the things we're seeing is that that it has higher rates of eligibility for the marketplace and higher rates of uninsured at the same time. And so part of that is because you can see here the economic characteristics include an abundance of small businesses, which means that people have jobs, but those jobs aren't going to provide them health care because small businesses can't afford it. So these people are going to be employed at a level below 400% of the federal poverty level. So they're not going to be eligible for Medicaid. At the same time, they're also not signing up for insurance, which is interesting, but also tells us we need to be reaching out more to the small business community, letting their employees know you do have access to subsidized health insurance. You just have to go get it. The business is not going to provide it itself. And then finally, this kind of just takes a look at the subpopulation within the county. And so you have a large population that's highly educated, they own their own home, which is linked to high market participation. However, the population is large enough and diverse enough that the average individual in Gwinnett County who does not have insurance is younger, lower income, single, and renting than the higher percentages of people in Gwinnett County are getting insurance. And so what we're hoping, and like I said, I can go super granular with this. This is like a really high level. I can give you like neighborhood data, right? But what we're really hoping to learn from this is why are people in Georgia not signing up for insurance that's available to them? And then how do we go about reaching out to them to make sure that they, or at least assist them in signing up for that insurance? And so this study has really kind of helped us start to ask the next set of questions. How do you advertise to the uninsured individual in Gwinnett County versus the uninsured individual in Glynn County, right? And so a more state-specific, a more local-specific advertising campaign, one that is multilingual, is multi-ethnic, sort of hits all Georgians where they are, I think is what's really starting to come to light here. We'll issue a more detailed executive report, but that's the summation of everything I have to present. If you have any questions about this study or the previous study, I'm happy to answer them, or I'm happy to provide you data on what's going on in your district if you'd like it.
Thank you, Mr. Chairman. I appreciate your presentation. You did mention several times, I think, the word "we" or something like that. What is the role of the Department of Insurance at a state level in giving guidance, oversight, control of an ACA plan? Is it similar to the lack of influence we have on ERISA plans and their setup, or is it? And then I know separately we have a 1332 waiver, which gave us some ability to maybe do some $50 reductions in premiums. Is that what gives us some opportunity, the waiver from a few years ago?
So the waiver, that's a good question. The waiver gave us what the reinsurance program is. And if you're not familiar with the reinsurance program, essentially state and federal dollars come together to backfill high-level claims from around the state. So there's an attachment point. It's about $20,000. Claims between $20,000 and $500,000 receive essentially a reimbursement from the federal government and from the state. What this does is lower the cost for the insurers of kind of high cost care, which enables them to pass on lower premiums to the local population. And so the 1332 waiver gives us the ability to sort of influence what's going on there, right? So we're able to move the attachment point. We're able to move, there's different rating regions in the state. And so that gives us the ability to lower premiums. It also has invited a lot more carriers. We've had 5 more carriers come into the market. So that helps with access to care. When it comes to ACA plans, so we do certain things with ACA plans and other things we don't do. So right now, we will regulate. So if you're a Georgian and you have an issue with your insurer under an ACA plan, we're the primary regulator of that insurer. We're the regulator of their conduct. We also take a look at their rate filings. They have to justify their premiums via their actuarial data and loss ratios. But we don't really have much to say about network adequacy right now. We have some levers we can pull with respect to the way that certain health decisions by an insurer will have an impact on a local population, but we don't have some broad network adequacy authority. We also, when it comes to ACA plans, I think there's a bill advancing in the Senate right now to allow the state to set up a state-based exchange, and that will return a lot of authority to the state of Georgia in terms of how to regulate ACA plans and the conduct of the insurers and the individuals who buy them.
Thank you, Mr. Chairman. So I came in latter part of your presentation, but I have a quick question around Medicaid unwinding. Right now is 2.7 million Georgians are going to have to reapply.
Correct.
And the budget accounted for $3 million to cover 382 people or something like this. My question to you is, what is the true number that we really need to take care of those 2.7 million who have to sort of reapply, if you know that? What is the number from a hiring standpoint, but also a retention standpoint? Because it seems artificially low given the estimates from the governor. So I'd just like for you to weigh in on that, if you could.
I mean, the Department of Insurance we don't handle Medicaid, so I can't really speak to what it's going to take for the reapplication of the 2.7 million people, or what the staff hiring is going to be, because that's not our department. I can say that I think every state is concerned about this sort of cliff we're heading towards on April 1st, when millions of people all across the United States are going to lose access to that those expanded Medicaid subsidies. I think our concern as a department is to try to let people know that they're going to lose health coverage and that they may be eligible for an ACA plan, and try to transition them. And that's sort of our piece of it. So I can't really speak to what it's going to cost to help transition that population. We're just going to try to help the people transition onto whatever resources are available to them. Sure.
Representative Knight.
Thank you, Mr. Chairman. Just a follow-up and clarification, and see if you could maybe expound upon the issue. I know earlier you said that there was, some evidence where there was, undercovered. There was not a lack of doctors.
Right.
And again, to clarify my question, not necessarily looking at it from a mileage perspective, but your chart showed that there were carriers that were engaged in those areas, but they didn't have, obviously, the insurance and the contract obviously did not include providers in that area. That typically is a contract, right?
Yes.
That the insurers, have. So from that perspective, maybe speak to it, and then how do we, quite frankly, that's, you know, that's the whole thing. That's sort of behind a curtain, if you will. How would you suggest that we affect that?
So I think when we're looking at the county data, there's two reasons you're going to see uncovered individuals. One reason is perhaps there are not enough providers. But if there are not enough providers, you're going to see the lack of coverage across all the insurers because there's just no doctors there. If it's a contracting issue, and some insurers have a big network and some have a small one, that's a tougher nut to crack. I mean, right now, what took place on January 1st is CMS mandated the drive time standards to the states. So this data comes from 2022. Before those CMS rules were law for ACA plans here. Now that those rules are in place, we anticipate seeing more providers come into those appropriate standards. However, that probably will not fix the problem. I do think that if you want us to address network adequacy in a more in a broader sense, we're going to need to take a look at like how do we regulate that in the state and do it in a way that meets the needs of the kind of the various communities around the state. So I don't think that we have the ability to do that right now.
Representative Lim.
Hi, thank you for the presentation. First, I wanted to make a comment. As I'm a member of the Gwinnett delegation, I really appreciate this level of data. I know that in my particular district, about 42% of the people are uninsured, yet of the adults, more than 50% of them work. So I see a lot of the analysis here. And I also just want to thank folks like DCH for working with me and others to ensure that we get some of that information on coverage to multilingual and immigrant populations. Just a quick question on the secondary is, I think you said that the uninsured population data was in 2022, like a point in time analysis. Do you have any sense of how this has changed over time at all? The open enrollment this year, we had about 200,000 more Georgians sign up for ACA plans. So this has changed. We're hoping to follow up this last year's study with a study of the population this year to see what's taken place. So we don't really know if it's changed, if those 200,000 people were proportional around the state, and so the hotspots are still the same. But it's still a significant coverage. There's still a significant gap between the number of people who are uninsured and the number of people who are insured. But it takes about 6 months to compile this. So, open enrollment just ended. I think we'll try to start compiling again in the spring. But we're really kind of hoping with both these studies to follow them up with subsequent studies. And then every year, if we can look at this data, it can kind of tell us where the market's moving. But I don't have like a sense for how it's changed since this data was collected. Not yet. Yeah.
Thank you so much. I really appreciate your information today, and I'm sure we're going to be speaking about this in the future quite a bit. Thank you very much.
Thank you, Mr. Chairman.
Thank you. Okay, now we'd like to hear from Kim Elliott
And Mike McBride.
and Mike McBride.
Thank you, Chairman Hawkins. Appreciate the opportunity to join you here this afternoon. My name's Ken Elliott. I'm with a company called Sage Therapeutics. Our mission is to pioneer solutions to deliver life-changing brain health medicine so that everyone can thrive. And that's what we're here to talk to you a little bit about is major depressive disorder and postpartum depression. I have my colleague Mike McBride here with Biogen. This conversation with you all today stems from a conversation I was having with Chairman Hawkins last week in his office about the burden of major depressive disorder and postpartum depression in the country, and he suggested that we come have this conversation. So thank you for the opportunity to highlight the issue with you. Major depressive disorder is a disease state that costs this country around $98 billion a year in direct medical costs. In 2020, some 21 million people in this country had some sort of major depressive episode during the course of the year. And a 2015 study showed that the average person that suffers from MDD takes around 7 prescriptions. So it's quite a costly disease state for our citizens. And postpartum depression, which sometimes is talked about separately, but also falls in this major depressive disorder category, is one of the most common complications during and post-pregnancy. Yes, thank you. Roughly 500,000 women a year suffer from this disease. You may have seen a tragic story that took place in Massachusetts just a couple of weeks ago, where a woman who was a nurse at Massachusetts General actually killed her 3 children and then jumped out of a second-story window. And she had been suffering pretty significantly from postpartum depression in that case. It was a tragic, tragic story, and we hear stories like this quite frequently. What we know is that there's no single biological or environmental incident that may trigger MDD or postpartum depression, and it affects people from all walks of life. Unfortunately, women are disproportionately impacted by it. Also, people ages 18 to 25 have the highest rate of major depressive disorder in this country. But really what we want to get to is some of the innovations that have taken place in this space in the last couple of years, and talk about how we've been treating these patients and what's on the horizon to make a significant difference. You know, the products that we're using to treat these patients with are SSRIs or SNRIs. The first SSRI came to market in 1987. The first SNRI came in 1993. There hasn't been a whole heck of a lot of innovation until relatively recently in this space. And now, you know, we know that it's not serotonin or dopamine that's the trigger for these. It's more GABA receptors and MDMA. And so there's a whole new wave of products coming to market designed to target these neuropathways to provide a different level of relief. I'm going to turn it over to Mike for a minute to talk about some of the policy implications of those.
Thanks, Ken. But before I get to the policy implication, I'll just quickly introduce myself. So Mike McBrady, as Ken said, with Biogen. We're one of the first biotechnology companies and call ourselves pioneers in neuroscience. Have been working in a lot of neurological conditions for many years, kind of known in the multiple sclerosis space, Alzheimer's, Parkinson's, ALS, and more recently have been partnering with Sage on MDD and PPD. But what we've, as we've gotten into this partnership, we've started to look at, what are going to be the access challenges for patients to take advantage of this new wave of innovation that we believe will be coming really over the next couple of years in terms of new ways to treat these terrible diseases. And fortunately, Georgia has done a good bit of work in the areas that we're targeting that will be a challenge. And a number of you have been around over the years. Some of you may be newer, but looking at reforms in prior authorizations and step therapy. So if maybe you're a newer member to the committee and aren't familiar with these terms, it's a quick little 101. But prior authorizations, or PA for short, is basically the standard process insurers use to basically have the physician seek approval prior to either a therapy or service being provided. And step therapy is something similar, and when it comes to medications, it's basically the case that you have to quote-unquote fail a drug, typically an older, cheaper drug, before you can actually try the drug that your physician recommends. So these are a couple common barriers that we see. And Georgia actually did some groundbreaking work back in the 2016 session on step therapy reform for a particular kind of narrow window of treatments through the Jimmy Carter Cancer Treatment Access Act, which basically did a carve out for certain types of advanced cancers from the step therapy process. And while we believe that the step therapy and prior authorizations do have roles to play in the healthcare marketplace, when we look at serious mental illness such as major depressive disorder and postpartum depression, we believe a similar case can be made for an exception from these diseases. As Ken talked about, a lot of these older treatments that have been on the market for many, many years, the time that it takes for these treatments to actually have an effect in the body averages 6 to 8 weeks. So if you can imagine cycling through, again, these kind of fail first policies of, trying something, waiting weeks to see if it's working, maybe trying another one, and because of that, ends up what's happening is there's a very, very high abandonment rate by patients on their prescribed therapies, and step therapy is one of the reasons for those. The real groundbreaking thing that we see happening with future treatments is the potential for these treatments to be faster acting, and so that's really what we're really excited about and hope to be part of a next wave of these treatments. I'll say, NAMI probably put it best why specifically serious mental illness should be accepted. And I'll kind of quote from one of their statements, but they say step therapy can be a danger to the health and well-being of the person taking the medication and result in worsening of symptoms and undermining the decisions made between individuals and their healthcare providers. For some healthcare conditions, some people can switch to a different drug without problems. However, for people with mental health conditions, step therapy has unintended and sometimes dangerous consequences. And NAMI is really one of the leading voices for the mental health community and has been looking to do work on this for a number of years. And just to kind of throw some numbers at you from more the provider side of things, a number of these groups have done surveys of their professionals and have found a few of these statistics might be of interest and relevant. So over at the AMA, the American Medical Association, 93% of physicians say that prior auths sometimes, often, or always result in care delays. Again, this is what we're trying to avoid. And then more specifically in mental health, the American Psychiatric Association has found a number of things. First, that patients were not able to access clinically indicated preferred medications because of drug coverage or utilization management issues, such as STEPS or PAs, in about 30% of the patient cases. So it's a significant number of patients who face these barriers. They also found that states with the highest rates of prescription drug management, again, step therapy and prior auth, had significantly higher medication access problems. And then finally, patients reported to have medication access problems were 3.6 times more likely than patients without access problems to experience an adverse event, which is basically a medical term for an unwanted side effect or negative unintended consequence. But beyond the numbers, I mean, really what we'd like the committee and this body to consider is, really this is an issue about patient and physician choice in their medications and believing that serious mental illness, given the severity of it and the consequence of it, the treatment dynamics, believe similar to what you guys were able to do for certain cancer treatments and looking to carve out for serious mental illness. So thank you guys for having us. Appreciate the conversation. I think we have time for questions should the committee wish.
Do we have any questions? Okay, thank you both very much for your presentation. We appreciate it. Great information. As the committee can see, David, I'm sorry, did you have a question? I didn't see it.
Tell you what, I'll get
We
with
do
them.
have a question. Excuse me. Representative Knight.
Thank you, and appreciate your care and what you're doing, especially in this space as far as talking about some of the mental issues that are going on out there. I also appreciate your comment about, physician and patient choice. It resonates. We've certainly, like you said in Georgia, we've tried to attack this issue. My question to you is some of your drugs, how are they being, in partnership with not partnership, that's the wrong word, but how are your drugs listed in the insurance? Are they specialty drugs? How are you seeing your drugs being listed within the insurance, different, if you will, markets or within the contracts?
Well, that's easier for me to answer than it is for Mike to answer, because Sage only has one product on the market currently, and that's for postpartum depression, and it's a hospital-administered drug.
Okay.
We're partnering on the development of an additional therapy that would be a more pill formulation, and it would be, it's probably most likely to be some sort of physician-administered or monitored type of drug in that case. So that's easier for me to answer. They have a much broader portfolio of drugs, so
Yeah, I'd say the drugs that Biogen already has on the market in other therapeutic areas, they tend to be more in the specialty space given the types of conditions that we treat. But for the drug that's partnered...
Is that, and if you will, question, is that by your choice or is that by the insurance choice?
It's more by the nature. When you use the term specialty, there's not a standard definition across the board, but generally it refers to higher cost conditions, chronic conditions, treatments that may need special handling, and then not like to be contrasted with something that's more of a mass market. But back specifically to major depressive disorder and postpartum depression, the drug that Biogen and Sage are working jointly on, that would not yet be on formulary. It's still in clinical works and under review by the FDA.
All right, thank you very much. Appreciate it. As the committee can see and our visitors today, this state is very well focused on the availability and access to health care, which includes not only insurance, but the new pathways and focus on mental health and treatments for mental health. Anytime we focus and really zero in on types of treatment, we find alternative ways and more modern ways, and so the future gets brighter, and that's what we're going to be about this year. So next bill is Representative Bruce, House Bill 124. Yeah. I told you I'm getting blind.
Thank you, Mr. Chairman and members of the committee. I'm going to be brief because I want to give others that are here an opportunity to be able to speak on this bill. But this bill was inspired by the reality that in the city of South Fulton and on the south side of Fulton County, it's over 200,000 people that do not have immediate access to ambulance services. And we don't have a hospital on the south side either. So we have a lot of people that they're at risk. I mean, really big risk. People are dying because they don't have access to the medical care that they deserve by being residents of this state. The last statistic I saw said that it takes about 30 minutes for an ambulance to actually get to where it's supposed to go. And we have fire departments within those areas that have the ability to get these people to medical care that they need, but they need the authorization to do it. And that is the purpose of House Bill 124, is to give them the ability to do that. We are in a situation where there are people that are concerned about the politics. I can't think of a better way of putting it. Concerned about the politics, concerned about the county procedures, and the reality is that we don't need to be concerned right now about the county and the procedures. We need to be concerned about the people in those counties and making sure that they have access to the service that they need. And right now, they do not. There will be some that will come before you to say that somehow the county is hurt by this bill, but the county is not hurt. We haven't been able to find anything in this bill that hurts the counties. It really is there to make sure that the people in these counties and these cities have proper access to healthcare services. So with that, I'm going to take my seat so that the members of the various fire departments are able to come up and talk about why they asked for this bill to come into place. Thank you again, Mr. Chairman and members of the committee.
Here's a question. Representative Mitchell.
Thank you, Mr. Chairman. Representative Bruce, your bill doesn't require that they have the transport them. It just, if they had the wherewithal, the ability to do so, they could.
That is correct.
Thank you, Mr. Chairman.
I'll waive.
Thank you, Mr. Chairman. Yes, sir. This bill, would this be a situation where you had a contract with the local community, but the fire department could supplement that, or is this?
It's intended for the fire department to supplement.
Who oversees, if you don't mind, who oversees the delineation of who has to respond, especially for one further away? Who would the fire department decide which ones to go to and which ones not to go to, or would the other contracted licensee, if you will, would would they oversee, the assignment to a fire department?
That's probably a better question for them when they come up, but the way I understand it, the fire department pretty much shows up before an ambulance does in just about every instance that I've ever seen. Right. They get there first. And if they're there and they determine that this person needs a medical coverage or medical assistance right now, and they're still waiting on the ambulance to show up, this would authorize them to go ahead and take the necessary action to make sure that this patient is not dead on arrival.
If you don't mind, would it also mean that if a paramedics did show up a few minutes later, a minute later, whatever, and transported the patient, would this allow an additional bill? Would this section's like 946 about authorized to bill, would it allow the fire departments to bill that patient or family in addition to the EMS?
Again, that's probably a better question for them, but my understanding is this is not an intention for the fire departments to be able to create a revenue source by any stream of imagination. This is just to make sure that the patient gets the care that they want to get. And if, in fact, the fire department provides that service, then they have to cover their costs. But this is not a bill or an authorization to increase the revenue for the fire department by any stream.
Thank you.
Representative. Thank you, Mr. Chairman. Just to follow up, because I want to make sure your prior question, usually your fire departments are part of an emergency response, personnel that are either belonging to your city or county, right? And again, getting back into where you're funding from, usually that's, the general fund of a local government, whether it's city or county, it's providing for usually, responses, whether it's the police department, the fire department. So again, I am curious what effect this would have. Is there intention to be a direct billing for services should somebody's, be called to someone's, home and response by our fire department? How is that? Do you know how that's working?
My understanding, again, the only thing is probably a better question when they come up, but as I understand it, if in most places right now, the fire departments are not allowed to transport. They're just not allowed to do it. And so in most instances, that's not being included in anybody's general fund right now. And what this would do, if it's approved, somehow it would have to be covered. They'd have to pay for it. And but again, I'm going to let them address that when they come up. But this is not intended. This bill is not intended to be a revenue source. It's intended to be an opportunity for people who don't have coverage now to get coverage and to get access to medical service. You're talking about over 200,000 people that do not have immediate access to medical service, and that's a lot of people. And so that's really what this is about.
All right, we have a few people that'd like to speak to this. Gabriel Carter, would you like to come up with ACCG? Yeah, well.
All right, good afternoon, Chairman Hawkins and fellow committee members. My name is Gabriel Carter, and I represent the Association of County Commissioners of Georgia, ACCG, and we represent all 159 counties throughout the state. I would like to first state that I appreciate this committee for allowing us to have an important conversation on EMS. At ACCG, we're in full agreement that there are tremendous healthcare disparities across the state, and we need to have an honest and thorough evaluation of the ways in which EMS may contribute to that. We wanted to speak before you today because counties represent a substantial part of the EMS system. Since majority of EMS is either run or funded by the county government, we wanted to just share some of the concerns that we have with House Bill 124 and the ways in which, through trying to solve a valid concern here in Metro Atlanta, may end up inadvertently causing further disparities in other regions of the state. So here to speak with me more about this, I have Mr. Courtney Twilliger. He is a public safety coordinator from Emmanuel County who also deals with EMS.
Thank you, Mr. Chairman. I appreciate the opportunity. I'm Courtney Twilliger, and I spent 46 years of my life in EMS, 45 of them at Emmanuel County EMS, and 43 of those as director. I've served on the regional council for about 44 years. I've served on the state EMS advisory council. I chaired that for about 14 years. I've served on the Georgia Association of EMS. I chaired the board there for about 12 years. The Speaker Ralston put me on the Trauma Commission and reappointed me twice to that group, and most recently Governor Kemp appointed me to the Healthcare Workforce Commission. So I've got some expertise in the EMS world. The bill as it's written, I think we'll call it chaos in 159 counties in Georgia. But I would agree that they have a huge issue where they're at in response times. I would disagree a little bit with one of the comments, because I'm going to read from the bill in its own section on the first page of the bill here. It says, any first responder falls under the department's rules and regulations governing ambulances and can transport only in life-threatening situations or by the order of a licensed physician or when a licensed ambulance cannot respond. So they currently have the capability of responding. It has, I think, in many cases, they have been perhaps confused by some people at the state government that think that they can't get a license. I think they can. They can't get a zone. The issue that we're dealing with is that the EMS law was written in 1973. It came from an initiative of the federal government that started off in 1966 with an issue about trauma. And the laws were written to create ambulance services that would take people from the scene to a hospital. Where I come from in South Georgia, we have a little bit less trouble with our response times getting to the patient. But what I'm finding in South Georgia is issues about getting patients transferred from one hospital to another. On the Trauma Commission, we just had the American College of Surgeons came down and did a study. We don't have their final report yet, but one of the things they recognized in rural Georgia was the difficulties of small hospitals getting EMS crews to take patients from that hospital to the tertiary center, the trauma center, the stroke center, and the cath lab, the cardiac center. So EMS has got a whole bunch of issues, and I recognize if I'm a firefighter on the scene taking care of a patient for a long period of time, I recognize that frustration. But I think if they look at the law and they work this the way it can be worked, they have the ability to do that now. What I'm afraid, my mama used to have a saying, says you don't throw the baby out with the bathwater. And I think in this bill we would be doing exactly that. In Emmanuel County, if this happened in Swainsboro, which is our county seat, dead center of the county, elected to start an ambulance company, that would do two things. One, it would take revenue away from the county government because it's the greater population center. And in doing so, now the county has got to service less people with the same amount of money and less revenue. So what you'd see is the city of Swainsboro raise taxes to fund that service, and the county have to raise taxes because they've lost revenue. So I think it's a killer on both situations. Again, what I would personally like to see is that the House and the Senate come together with a joint study committee to spend some time looking at all the ramifications that this bill and others like it may impact our industry and the life and safety of the folks in our state. Because it's not just an urban area issue, it's a rural area issue. And today, a lot of smaller hospitals are having to go fund a contract to have another ambulance company come and make their transfers. And oftentimes that is a delay in half an hour, 2 hours, or longer trying to get another service to come into that community and do that transportation.
Thank you. Any questions? Okay. Next presenter, Chad Jones, South Fulton Fire. That's what that is.
Right here. Well, good afternoon, Chairman and committee members. Thank you for the opportunity for us to come and actually speak on behalf of this bill. Want to thank Representative Roger Bruce for taking the time to listen to us to introduce this. I don't think anybody in the room will disagree that there's got to be a change, that what is working now is not working, it's broke. And at the end of the day, it's about our citizens being able to be transported to a hospital, period. So it's about accountability. So I'll tell you a little bit about South Fulton. So South Fulton is a city in the county. We don't own the zone. We don't want the zone. The zone is with the county. So the county contracts EMS. So for the cities, we have no way of being accountable. So when the constituents calls and says, why did it take an hour to get an ambulance there? I have to tell them, we were on scene 6-7 minutes as the fire department. It's the ambulance. There's no accountability. So what this bill does, it helps bring accountability for cities such as mine. It states in here that if you have a fire department, you're able to get a license, a transport license, not going out to the zone, transport license. The reason that is so important is in the existence of South Fulton, 5 years, we've applied 3 times for a license. We've been denied 3 times. You'll hear some of my colleagues with the same stories about getting a license. Why is that important? National response times, 5 minutes for BLS, 9 minutes for ALS. Something that this committee and the House and Senate just had happen to itself last year. You had a member that had a cardiac incident. It took over an hour to get an ambulance here. Now you have on staff or in the building, you have EMS. I'd like to do the same thing for my constituents of South Fulton. Talk facts. January of this year, South Fulton Fire ran 1,200 EMS calls. For the county, or the South County as we call it, the cities down there, 1,900 EMS calls. When that person called 911 in my city 120 times, there was no ambulance available. For our area, 190 times. That's 10% of the times that someone called for an ambulance, there wasn't one available. As Representative spoke, we don't have a hospital below I-20. So usually those ambulances that are already transporting are outside the county. They're in Clayton, Fayette, Coweta, Douglas, Cobb, or north of I-20. Easy, a 30 to 45 minute response from that hospital to the location that I have a fire truck sitting there trying to provide care. How does that also play into fire? There are several times last year that we didn't have a unit available to go to a structure fire because of the fact they were sitting on an EMS call waiting for the ambulance. It rolls downhill. So what do? We can put up rescues. The law says I can't call an ambulance, but that's taxpayers. Without a transport license, my city has no way to bill. In this bill it states, for transport only. So if we did have to transport. Representative, you asked a question earlier about how would they be dispatched. We are in South County, the cities and the ambulances all dispatched by Fulton County 911. They're going to immediately dispatch fire. If they were to say, and again, it's up to the municipality how you do it, but if they were to say there's no units available, if I had a rescue, I could send them. We fall up under national standards and state standards. So if it is a high priority call, they are triaged, Alpha through Echo. Charlie, Delta, and Echo are serious calls. Usually they're the ones that are cardiac arrest, someone not breathing, someone shot, car wreck with entrapment, pending life. We have a rule, 10 minutes on scene, an hour to the surgeon. If I got to wait an hour to get an ambulance to the scene, that patient does not have the same chance as anybody else to get to that surgeon. Children's Healthcare of Atlanta is the closest to us. That's a 45-minute drive in good traffic to get a child. We use air a lot of times. We fly them to make sure they get there. So what we're asking is, in this bill, is to look at it in its totality. These laws have been on the books for a long time. Help us to gain accountability. What the departments are asking is, let me get a transport license. I can put up rescues, I can put up ambulances, I can staff those to supplement. We don't want to take over EMS. We don't want to stand up our own EMS, but also help my taxpayers. Because if we do have to transport someone, we have a means then to do cost recovery, not a revenue stream. Thank you.
Good afternoon, Chairman. My name is Wade Elmore. I'm the fire chief of the city of College Park. I've been in the fire service now for 31 years. I've always worked in South Fulton County. I've worked for Fulton County for 14 years. I've been with the city of College Park for the last 17 years. I wish I could stand here and not repeat what Chief Jones just said, but I have to. Our city is 11 square miles. It takes us, on an average, 4.5 minutes to respond on an EMS call. Last year, we responded to over 7,000 calls. 80% of those calls were emergency medical calls. I have two, what we call rescue units, the ambulances. I have paramedics on staff. I have emergency medical technicians on staff. It takes us 5 minutes, like I say, 4.5, 5 minutes to get to the call. But we have to sit with the patient unless it's a life-threatening situation. If it's a gunshot, stabbing, that's the only way we can transport. Other than that, if it's a broken leg, broken arm, we have to sit there while the patient's in pain. We have to sit there. Over the last 2 years, we've sat on scene on average for an hour and a half waiting on an ambulance to come and transport a patient to the hospital. And as Chief Jones mentioned earlier, we're sitting on scene, our units out of service, so we can't respond to other calls. So what we're doing is, the priority are our customers. And when I say customers, that's our citizens. When they dial 911, they expect A1 service, medical care. Right now, we're not providing that. And I would say over the last 2 years, it's been that way. So, with this bill, we just wanted to give us an opportunity to make a decision, to be allowed to make a decision on who transports, or if we want to transport, we can, or we have a say-so in who can transport in our area, in our zone. Thank you.
Representative Sharper, I think you have a question.
Oh, thank you for the opportunity, Chairman. I've been an EMS paramedic for over 30, 32, 33 years. And as I listen to the big picture of what's going on, I would say, and you mentioned the numbers of how many calls you have to go on, I don't think this is a situation where your fire department needs to rescue the ambulance service. Because like you said, if you guys are on a call, on an ambulance call, EMS call, then you can't get to where you need to get to far as your fire. What I think needs to happen in most counties, like a lot of the cities say, we're going to let the county decide who's going to do the ambulance service, where it's a hospital doing it or where it's the county themselves, county employees. But I think this effort needs to go towards this specific county. If they're having this problem this bad, the numbers will justify that more money needs to be placed in getting more ambulance personnel and ambulances to respond in the county. I started in Loudoun County. We had years ago maybe 2 ambulances, then we got 3, then we got 4, then we got 5, because we saw the need and we didn't want, you know, the fire department, anybody else, to have to come in and do things for us. We have other counties that can help out when something happens. Mutual aid, if you will, And I understand the fire department gets there and do what they can if they have EMTs, paramedics, but you're going to see something happen all across the state if this happens, because in most times, your city fire departments can get to any patient quicker than EMS can. But the problem, you guys are doing your job and what you can do, but if there's a transportation problem and also EMS problem, we need to focus on the EMS problem and hold the counties and the county officials and the city officials, hold them accountable to get the funds needed to do what they need to do as an ambulance service. So I just wanted to put that out there, that we appreciate and we see that you guys can get quicker response, but the liability in all this, then once somebody does it with a fire department and is doing great, then some of the other fire departments may say, well, we want to get ambulances, we want to get EMTs, we want to get paramedics and things like that. So there's a lot to think about. But I would say the main objective is to get the counties to supply the ambulances and personnel that it needs to get quicker responses. And I think that's where I would start, to see what can happen on that end first, especially in your particular community. Thank you.
Thank you. Representative Newton.
Thank you, Mr. Chairman. First off, I really appreciate the fire department. I'm an emergency physician for over 20 years, and we see the help that having fire and EMS respond is just so vital and life-saving in many cases, and definitely helpful too in transport cases. I do see a little problem. These are, correct me if I'm wrong, are these typically EMTs or paramedics that are doing this transport?
They're both for the fire department. We have both EMTs and paramedics.
One of the challenges, and speaking to Representative Sharper's issue correctly, is that one of the reasons EMS is not responding as quickly is because of some of the struggles in the hospitals and the emergency rooms, to where the paramedics deliver a patient, and previously they would have been gone in 15 minutes once a nurse was available to take report and to take over care of that patient. Now they're being asked to stay 1, 2, and 3 hours sometimes. Therefore, it delays, it gets you that 1 hour response time, and then it just keeps rolling and is inadequate. In our problem, frankly, it's not even just an EMS problem. It's we've got to find a way to release EMS to do what they do. So we are working on workforce, we're working on healthcare, we're working with our hospital partners. I do question whether or not bringing in people, are those firemen going to be able to stay at the emergency department caring for a heart attack patient for 2 or 3 hours, or are they going to really just transport and that's it?
Well, I can speak for us. We would have to look at it. We would probably have to increase our staffing and units. Because right now, I know City of College Park, we have 2 rescue units that respond on the calls. And they transport from time to time, if it's, like I said, it's cardiac arrest. But once we deliver them to the hospital, they'll get back in service.
Well, I hopefully can work together on freeing up EMS to do what they do, then have the counties and cities demand or expect a contractual response time, measure it, deploy it in whatever way we can. But I look forward to working on a solution. Not 100% sure this is the one best answer for 159 counties, but I look forward to the conversation. Thank you, Mr. Chairman.
Thank you. Representative Mitchell.
Thank you, Mr. Chairman. Based on what I've heard here and how hard the representative has worked on this issue and how all the concerns seem to be addressed at the appropriate time, I'd like to make a motion to pass.
Oh, this hearing only.
Yeah.
Thank you.
The reality is that the representative made such a grand presentation. I know that the chair could decide that to give the committee a vote on this issue.
Thank you. We haven't even heard all the testimony yet. Thank you. Representative Knight.
Thank you, Mr. Chairman. Nice try. First of all, to the firemen and to your departments, I know I don't live in your area, but thank you for what you do. I know that in my area, we've personally had family issues in which you guys are the first ones on the scene, and I appreciate you, and I appreciate what y'all are doing. I guess my question goes back to, and maybe jumping on Representative Sharper's, his point is, where is this broken along the line, okay? And a lot of times we all want to jump up and fix it, but it looks like I would personally want more information, because as I had raised the point about taxpayers, and again, Chief, if you'll bear with me, in College Park, you guys lie within 2 counties. Am I correct on that?
We do, Fulton County and Clayton County.
And Clayton County. So again, we go back to our local jurisdictions and our governments. The responsibility in a general fund is to provide services, right? Correct. That everybody has access to, no matter if your home's on fire. If it is, you hope you never have to use your services, right? But if you do, everybody has access to it, right? It's part of the general government perspective. And so your citizens that you're representing in College Park also live in 2 different counties. So they're getting taxed, if you will, by 2 different counties in your case, and it could be 1 county in other parts of the Georgia, that they're supposed to be providing those services. And it sounds to me that we have a problem in some areas where it's inadequate. I'll leave it at that. Would that be a true statement? So I think we recognize some of the issues and problems here, and quite frankly want a solution. But in the end, if our taxpayers are paying for something that they're not getting, then I would appreciate, and maybe you've got some information, or we can get some more information from the committee, of where the breakdown is currently and where our current tax dollars are being used, okay? And why is those services, why are we not up to par here? And there could be workforce issues, or it could be, like Dr. Newton just stated, there could be a whole host of reasons. So don't take this as being not sympathetic to the issue. Actually, it's trying to figure out where we go and where the problem is, and then again, this is going to be a costly issue, and I don't want our taxpayers, whether it's in your county, my county, or any other county, to be paying more, if you will, when they're already supposedly paying for some of these services. And I don't know if there's a question there or a comment, but one, I appreciate what you're doing and recognize the issue.
Thank you.
That's just concerns that I have, but I'd like to. Okay. Can you address them?
Well, I just respond to that. Clayton County, we're not having an issue. It's only in the Fulton County portion of the county is where we're having an issue.
Okay.
Okay, thank you.
Mr. Chairman, thank you so much. Ron Taylor, I'm the Division Chief of Emergency Medical Services for the City of College Park. I've spent the utmost of the last 25 to 30 years serving in some capacity in South Fulton County, from Fulton County to College Park to East Point. This issue has been a 20-year issue. This isn't new. And so we've attempted to hold others accountable, but where we are today, those men and women that respond to emergency medical services, they are leaving, they're left holding the bag, as you will. We're keeping our units on scene for calls that they should not be there waiting for ambulances. I don't know how else to wrap this up. These units aren't available to go to true emergencies because we have a situation where they have to stay until an ambulance shows up. And so our backs are against the wall. And so when we hear, we want a resolution, don't get me wrong, but we want to be a part of the problem today. Not 5 more years, not 2 more years, but today. And I think this bill truly helps us to help the system. We're working with an antiquated system, no doubt. It may have worked 30 years ago, but today's market, there's a different need. Each jurisdiction has a different need from the system, and we're not getting that. And so we, as leaders in the EMS community and the public safety community, we have a right or a duty to address the system. And I do believe this would give us that help in addressing the system. Not that we want to be ambulance services. We want nothing more than to be able to move Ms. Jones from her house to an emergency room and get back in service and be prepared for the next call. Right now, we do not have the resources or the ability to do that, and I do believe House Bill 124 would give us that opportunity to do it.
Representative Petrie.
Thank you, Mr. Chairman, and thank you, sir. I want to ask a question. This is similar to what I heard from Representative Knight and Representative Sharper, but so you mentioned, sir, the duty you have to the community, and I agree with you. So can you help me to understand this? It sounds like we've got a problem in Fulton County, okay? But we're not hearing this, you know, I'm in Savannah. I've never heard this. Doesn't mean it doesn't happen. But so you would also agree that you have a duty if there is this failure. How forcefully are y'all making this problem prominent in the community in Fulton County? Because as Representative Knight was saying, the people are paying for emergency services, and if they aren't getting them, one would think that they are aware of that and that they would be doing everything in their power to fix that. So I also want to ask you, before you answer, are these services provided in Fulton County by the county or by some private contractor? Are they provided by county employees?
These services are being provided by a private service.
In Fulton County?
That's correct.
Because it sounds like in College Park, y'all are in 2 counties.
That's
and you really
correct.
only see this problem in 1 county. And so the common theme here is this a Fulton County problem. And of course, we're talking about a statewide statute. So help me to understand that. How aware are the people of Fulton County with these failures?
Chief Jones, would you speak for Fulton County?
Thank you for the question. I want to answer it in 2 ways, too, because you kind of asked to. We make it every day. The reason most of us are here is because our mayor and council, they've gone to the county, they've tried, they've asked us to get transport license to help. They're willing to be part of the solution and not the problem. So every day we're talking to them. The other question is, kind of got a little ahead of myself in the introduction, but I'm the 2nd Vice President of the Georgia Fire Chiefs Association. So thank y'all for what you do, and hopefully y'all come over tomorrow for the legislative dinner. Make a shameless plug while I'm up here. I've talked a lot, especially in cities all over, and it's the same thing. That when I talk to them, they have those issues. They don't have accountability because by the way it goes is the zones. So whoever is awarded the zone then goes out and gets whoever. It could be the county service. It could be that they contracted a private service. But there again, the cities within inside that have fire departments are having the same issues. Because again, and you talk about the tax burdens, things like that. My citizens, we're talking to them. You know, this is what it's going to cost to give you good service. The one thing, without a transport license, you're not eligible to bill. So just like College Park, they have no means. They're already paying for the rescues. They're paying for the paramedics, the equipment. It's over $100,000 per ambulance just for the equipment. They're willing to do that because we're here for the constituents. So at the end of the day, with the transport, we could do billing. I retired from City of Atlanta. We did the same thing at the airport. It's called soft billing. You bill, and what you get, you get. You don't go after anybody. But that's up to each municipality on how they'd want to do it. So it's not wanting us to start up an ambulance company. It's us actually wanting to be part of the solution and to augment. To the one gentleman's question, he talked about the doctor, you know, we'll be waiting. We know we've been tracking with DHR wall times. And again, the lack of nurses, the lack of paramedics. We're coming. I'm on the committee for workforce with GMA. We said we got EMTAs. We have paramedics. We have rescues. Let us supplement. Let us help and solve the problem. So that's what we're asking today.
Thank you, sir.
Representative Kemp.
Thank you for this. I think we all agree this is an important problem to solve. Just a couple of quick questions. Do you anticipate that you'd be able to bill lower, that there would be a cost saving to consumers in some way, that you would be able to charge less than, say, the county would charge for comparable services? And related to that, like, how would you avoid another layer of potential surprise billing?
That's a great question. I know in my city, everything from fees are done through the municipality. I know when I've worked for ambulances, there was the rates and things like that, Medicare, Medicaid insurances. So I don't think we'd want to compete with them. We'd want to work with them. There's already state law that allows us to do certain things, hazmat and car wrecks. So that would be a question down the road as far as the billing or cost savings. We wouldn't want to compete. We want to work with them.
Can you make this quick? Because we need to move on. We got 2 more. We got another bill.
All right, be real quick. Just to follow up on that, most of the times, I mean, I've been in city government as well. 20 years ago, city council and mayor pro tem. And a lot of times it's a standard for a lot of your city governments to sign over the opportunity for the county to handle that. And you mentioned something about a private ambulance service. The thing of it is, if that company is not doing what they're supposed to do, these things usually come up for bid. So I think the pressure needs to be put on the county commissioner and the city council, whatever you have, and make that company be accountable for what they need to do. I mean, that's an issue that needs to be taken care of. I just want to add that. That's where we need to start with first. Not saying we can get to what you're talking about, but that's where it needs to start.
Thank you. Okay, next up, and thank you three very much. Councilman Joe Karn, College Park.
Thank you, Mr. Chairman. Thank you for the opportunity. My name is Joe Karn. I serve as a city council member in College Park. I've also served as the Fulton County Commissioner for several years in Fulton County, representing all 9 cities south of I-20. A lot of the questions and issues with this bill, I think what we're looking for essentially is an option. Cities are looking for an option to supplement lack of services and capacity. I don't think there's any county, in terms of the densely populated counties. Yes, counties bid those services out, and all the cities within this county or within this region are locked into that service without a choice. The cities just want an option to have additional supplemental choice. You could bid that out every single year. No matter who you got, there are not going to be enough ambulances in densely populated areas to serve everybody in a timely manner. Ambulatory response time is one of the most crucial issues that we're facing throughout Georgia, throughout the country for that matter. I represented a lot of taxpayers, $250,000 at one point. On the city level, there are a lot of people that pay their taxes and they don't need city services. They don't have kids for parks and recreation. They don't have kids in school. They're not interested in the additional services. They pay their property taxes and live for decades in these cities. And the one time that they actually need those taxpayer services are when they have a life emergency. And that is the one time that they're left on the hook and waiting far too long in terms of response times. And they paid in all their life, some of them. And this is the one time where they need the service. I do not believe this will hamper the counties at all, because it only gives the cities an option. Counties throughout the state, some of them do not have the financial means as cities do. Some of them have better tax digests because they're more densely populated. So I think this would not hamper the county's ability to do what they need to do. It's only an additional option for cities that feel that they need it. And cities would be paying the freight for this. And speaking regionally to it, from my area, we've lost the 2 hospitals in Metro Atlanta, Atlanta Medical South, as well as Atlanta Metro. It used to be the Georgia Baptist, that's what I remember it as. I represent the airport area. We have populations that swell over 300,000 people in that region, between East Point, College Park, Hapeville, South Fulton. We get a lot of company down there. We have about 100 hotels or over and motels throughout that area. So from a regional perspective, for our visitors, ambulatory response time is very important. Hartsfield-Jackson International Airport, at one time had designated the South Fulton Hospital as the designated disaster hospital for any major airport incident. Obviously, that's not happening anymore. Ambulatory response time is important in a lot of things that we deal with. We have the second largest convention center in the state, the Georgia International Convention Center in College Park, as well as a brand new arena that hosts national teams that come in weekly with tens of thousands of people. Ambulatory response time is going to be very important to all of us in the region. In Hateville, which I represented as county commissioner, Porsche's North American headquarters are there, as well as several other hotels that have popped up. Woodward Academy is the nation's largest private school located in the city of College Park. We worry about incidents every day where the response time from the region contracted ambulatory response is not adequate. We just want an opportunity as a supplement, as an option for us in the event we need transport. And yes, it would be transporting to the hospitals so that we can get folks to the care as quickly as possible. The cities would be paying the freight for this. This is not a for-profit issue here. There would be no surprise billing from my city, I can tell you that right now. This option would be a not-for-profit option. This is an option just for better service. And I think it takes the burden off our county partners somewhat. So we're simply asking for an option. As you know, and lastly, our fire departments primarily serve as medical departments, because over 80% of the calls in the metro areas are actually medical calls and not fire calls. So it lends it where they can get more to their core service and takes the burden off of these counties as well. So thank y'all so much, and I hope y'all can give it serious consideration.
Thank you so much, too. Chad Black. He is with the Georgia EMS Association.
Thank you, Mr. Chairman. Like Courtney, I've got 40 years fire and EMS, where I retired as deputy chief of one of the larger departments in Georgia, operating EMS under fire, and then went up to a more rural county my last 5 years and merged fire and EMS as public safety director and chief. So 16 years air medical. I've chaired now since Courtney the State EMS Association. Everything that's said by the fire chiefs and everybody here, EMS does have problems. Nobody is saying that we don't, and it needs to be to the forefront. You had some great questions. The workforce issue started way before COVID. The main thing we're hearing is RNs shortage, which there is, law enforcement. EMS started way before any of that did, and continues, and nobody's addressing that issue. Wall times in some areas are 4 to 6 hours for an ambulance to transfer. And if it's a critical patient, a heart attack or something, they take them, but more stable patients, they are not. So those things have to be, I agree with the fire chiefs, we need to come together. We need to find solutions, but this bill in most of the areas of the state is not good. And South Fulton has issues. When I was fire chief, deputy chief in Hall and Habersham chief, that was my responsibility. I'm concerned about it. But when you start changing state laws, you've got to look at what it does for the entire state. From a billing standpoint, this law cannot tell them they can bill. You have to have a federal NPI number, National Provider Identification Number, to bill any insurance, Medicare and Medicaid, and you have to be a licensed service. So this law, if it says they can bill, you cannot just go out and randomly send somebody a bill. Insurance is not going to pay it, nor is Medicare or Medicaid. So there's processes you have to go through in operating a licensed EMS agency. Most zone providers in the busy areas, this is happening in DeKalb. You can call and you're waiting. They've got what they call no unit available. They're having to triage calls. It's not isolated to one area. There are major problems that needs to be addressed. But this bill hurts counties. Where I came from, Hall and Habersham, if cities would have got in and they're starting to run their zones, you're going to take calls away from those county services, and they've still got to provide for that for certain calls. The other thing is, most of your zone providers, and I've talked to the one in Fulton County, they will sign an MOU with a city fire department and allow them to transport if they don't have a unit available. That come directly from the vice president that does the zone in Fulton County today. I will sit down with them and we will sign an MOU if they've got a transport vehicle and we're not available. They would advocate that, so I encourage to sit down and talk to them. Georgia Emergency Medical Association would be more than happy to start those conversations and help any way we can. But we've got a lot of paramedics that are going to the RN field and a lot just getting out of the business. The workforce and the wall times play a crucial role in this, and you're exactly right, sir, in the delayed responses due to that. I would say that this body and the Senate, Georgia Fire Chiefs Association, firefighters, and GEMSA, that there's a study committee created to look at this, and let's work toward a solution, because they're exactly right, sir. There is a problem, but this bill does not help it. It only makes it worse right now as written. Not that it can't be something fixed and looked at, but we need to work together for a solution and not make a knee-jerk reaction. But I greatly sympathize and empathize with them for their citizens. They do have an issue, and this is something we need to work on. Anything?
Joshua Mackey, also with the Georgia EMS Association. I guess I'd just say two things. First, the specifics of the bill. If the goal is to be a supplemental provider, sections 3 and 4 specifically would allow the municipality to be the primary provider, and so it would drastically affect the 911 zoning system. So I think if the goal is to be supplemental, I think some changes to the bill could lead this in a better direction. Additionally, you know, as Chad said, we have great sympathy for South Fulton. There's been issues with ambulance services before. The state actually designates 911 zone providers throughout the state. A couple years ago, they actually changed the zone provider from a private service to Grady EMS, who does it now. So I think as these issues, if they're continuing, there's an ability to have a conversation. The state has shown in other parts of the state, it will change the zone provider if there's an issue. I think, as Chad said, there's an opportunity to sit down. We've offered up a study committee to both the House and Senate to look at these issues, and so we're ready to help. I don't think the bill as is written is a good solution. I think it would break up the 911 zone system.
Thank you. In the essence of time, we have this room for about 20 more minutes. We got a resolution we're going to listen to that I think is an important resolution. I want to thank the author of this bill for bringing this. I think there's been some very good points made on both sides of this issue. I think definitely there's some things to be looked at. This is for hearing only, but I will say, if you folks get together and come back with a better plan, we'll try to do it this session. If you cannot, then you may be looking at a study committee. But this is about saving lives in the state of Georgia, and that's utmost important to us and the people of this state. Thank you all for coming today. I appreciate it. Okay, House Resolution 43, Dr. Michelle Au, and Representative.
Good afternoon. I'll be succinct because I know we are running out of time. Thank you so much for this chance to present H.R. 43, which would create a bicameral study committee to evaluate the health costs of tobacco smoking in Georgia. For those of you that I don't already know, I'm Representative Michelle Au. I represent the 50th House District, which includes Johns Creek and Alpharetta. But when I'm not here in this building, I'm a practicing physician in Metro Atlanta, and I also have a master's degree in public health, and both experiences sort of inform a lot of the legislation I tried to advance. So I've been working on this particular issue for some time now, and I look forward to persuading you on the ways that such a study committee could do the necessary work to tee up measures, both legislative and non-legislative, to bring down state health costs and improve the quality of life for generations of Georgians. So I recognize this is just a hearing, so in the interest of being efficient and taking up as little time as possible while giving you as much information as you need, I've compiled a packet of materials, tabs, beautiful. I went to med school. I'm going to walk you through this as we weigh the value of this committee. So let's talk about first just why this committee and why now. Okay, so as far as I've been able to ascertain, Georgia has not looked at this issue of health costs of tobacco smoking in the state for at least the last 2 decades, which is the last time that the state tobacco tax was raised. So there is national data out there, which we're going to talk about, assembled by a number of departments and organizations, but this legislature itself has not taken a deep, considered, analytic look at these state-specific costs in at least the past 20 years. Second, let's talk about what I mean when I say health costs of smoking. This actually encompasses several different things, and the most classic understanding is that it's, just what it sounds like. How much are we paying to cover the health costs of those who choose to smoke, right? What is the breakdown of how these costs are paid? How much is paid via state health insurance programs? How much is paid through Medicare or Medicaid or private insurance? Who is incurring these costs, and how has this changed over time? That said, there are other expenses that are important for such a study committee to evaluate as well. What is the chronic disease burden on our society that results from smoking? What is the cost to industry and worker productivity of chronic diseases that results from tobacco smoke? How many days do we lose? How many life years do we lose from the burden of smoking? What is the cost of smoking on quality of life? Further, this is not a burden just borne by adults. Children also suffer the effects of secondhand smoke, and teen smoking or vaping is an issue that we also face. So what are the costs of childhood asthma, chronic absenteeism, misschooling? What are the costs of pre- and perinatal tobacco exposure? What are the costs we see in terms of at-risk pregnancy, preterm births, low birth weights, and perinatal mortality? These are issues that I know this body really cares deeply about, and we've talked about it for many, many sessions. So let's dive into the package, just because this is the best way for you to get this information without me wasting too much more of your time. I encourage you all to bring these back to your offices and read through at your leisure and consider your vote on this study committee. So the first tab, pink tab, gives some basic figures about national health care spending attributable to adult cigarette smoking. I'm going to note just one thing here, which is that of the $146.2 billion cost calculated, 64.5% of that was paid through public health insurance programs, meaning state and federal dollars. The second thing I'm going to note, actually, is that these figures were derived from a study published by the Journal of Preventative Medicine in 2021. However, this data pulled from national data from 2010 through 2014, meaning these figures are both far too general and also more than a decade old. So for the interest of our body, it would be prudent to try to extract more current numbers that are both more Georgia-specific and more, recent. Okay, so the second tab, orange here, gives figures on the toll of tobacco use in the United States from a document that was updated just last month. I'm going to point out a few key figures which puts the total state share of Medicaid payments at $30.7 billion per year, and the annual losses from smoking caused premature death and smoking caused illnesses at approximately $180 and $185 billion per year, respectively. Again, a study committee could clarify how much of this cost Georgia specifically bears annually. Third tab, yellow, is interesting because it actually highlights an intervention, which is something this body could affect. This is a study published in the Journal of the American Medical Association Health Policy Open Network, which looked at the change in Medicaid expenditures associated with decreasing cigarette smoking prevalence by just 1%. Right? So this study extrapolated that even this modest decrease of just 1% could decrease Medicaid costs nationally by $2.5 billion, or a median of $26 million per state, just by reducing 1% of smoking. This was an economic study conducted in 2019, so if you're interested in this result, I encourage you to also look to Representative Stevens' bill, SB 191, which is co-sponsored by many members of the Health Committee, including our esteemed chair and vice chair and myself. Moving on, the fourth tab, green, is an economic modeling study from the medical journal The Lancet, which seeks to extrapolate the economic losses attributable to smoking in the United States. This is a 2022 study conducted that the annual combined loss of income and unpaid household production at the national level was $436.7 billion, equivalent to 2.1% of the U.S. GDP. That's a lot. Okay. It's a math-centric body. That's a lot of money. So to be able to extrapolate such numbers specific to Georgia would be helpful, and that would be one of the goals of this study committee. Finally, last one, fifth tab, blue, is from a 2017 review of the Journal of Current Opinions in Pediatrics, and walks through an assessment of the role of tobacco smoke exposure and its resultant harms to children. So among others, it details many things, but including in utero exposure to tobacco smoke and its effect on poor birth outcomes, the effect of tobacco smoke on lung, cardiovascular, and brain development, its effects on placing children at increased risk of adverse health outcomes, including obesity, behavioral problems, childhood asthma, and nicotine addiction, all of which can have long-term effects on their school attendance, performance, and future productivity. So these are all important metrics to consider when we look to health costs for the future of this state. There's a huge amount of interest in such a study committee, and many community partners are already invested. Specifically, we have interest from the American Heart Association, the American Lung Association, the American Cancer Society, the CDC, and the American Association of Pediatrics in helping the study committee to do its work. In addition, the nonprofit Georgia Healthcare Foundation had offered such a study committee, if we form it, funding for a research fellow to do the skilled work of compiling and analyzing all this data necessary to produce a committee report of the caliber that this body would demand. We're almost done. So one dictum of the scientific method is you have to know, if you want to know if you're fixing a problem, you first have to measure it, right? So my goal in forming this study committee is just that, to form a bicameral, nonpartisan study committee composed not just of legislators like us, but also experts and stakeholders to do the homework for the Georgia General Assembly to produce a body of research that is necessary for us to take action on this costly problem that we really can't afford to ignore. Thank you so much for your attention, and I'm happy to yield for questions if there are any.
Representative Knight.
Thank you, and thank you for your concern in this area. I do have a little bit I know this has been an issue. I've been here since '05, and I know that the state has addressed some of the issues, short of outlawing, smoking. We've made sure that, the areas, the laws regarding where and when, has helped in making sure people are aware of the health issues. Is it true, though, since about 2005 or so that, smoking went from about 22% down to 19%?
That is true that smoking prevalence has decreased, and that's actually a really important reason to do this study committee. I want to be clear that this is just a resolution to form a study committee to look at the numbers where they are now. Since we haven't really updated our numbers in really the past 2 decades, we really want to see what the changes are, what the costs are that we're incurring now, and look for avenues that we can further work on decreasing these healthcare costs.
And I certainly appreciate it. Someone who's concerned about healthcare cost and has done a lot of work in that area for the last 7, 8, 9 years. I do appreciate that. But I also see that it's talking about suggestions for proposed legislation. And, you get into some issues of that old saying, you can lead a horse to water, but you can't make it drink, okay? So legislation that is dictating if outlawing something, and if we're on that issue, should sugar be outlawed? I know that diabetes and things like that are probably even more prevalent with healthcare costs. So what proposed legislation would you come out of this that would dictate, state acting in a way, to look at this and cause it? Because again, you start to cross lines of what everybody else could define as a healthcare issue. Where's your balance or tipping point there?
Certainly. So I think that as with any scientific study, you don't prejudge what the outcome is going to be. And really the goal of a study committee is to see where we are and to use the results of the study committee, whatever the results show, whether it's surprising or unsurprising, whether it's what we would expect or not, to guide our next steps, right? So this is not a study committee used to reinforce something that I already believe. The point of a study committee is to uncover what the problems are so we can act next. So I actually don't have a specific, this is not derived in order to push some sort of agenda that I have preconceived. It is in order to see where we are at this moment in time.
Thank you.
All right. Thank you all. This brings us to the close of this meeting. Thank you.
Thank you.